Tucked beneath the liver lies the normal, piriform-shaped gallbladder. It acts as a reservoir to concentrate bile and secrete mucin. In conditions like periampullary obstruction or an aseptic mucocele, it retains this classic pear shape and maintains its side-to-side mobility on clinical examination. But if that mobility vanishes and the piriform outline is lost, the clinical suspicion immediately shifts toward gallbladder carcinoma. To safely operate in this region, surgeons map the anatomy using strict geometric boundaries. This diagram outlines the hepatocystic triangle. It is a broad area bounded by the inferior edge of the liver, the common hepatic duct, and the cystic duct. Within that space sits a much narrower surgically vital zone. Callot's triangle is defined by the cystic artery superiorly, the cystic duct, and the common hepatic duct. Navigating Callot's triangle reveals the cystic lymph node of Lund. This is a critical anatomical landmark during dissection and serves as the sentinel node for the subserosal lymphatic spread of gallbladder cancer into the liver. Precise isolation of Callot's triangle establishes the critical view of safety. Without this visual confirmation, dissecting this area risks catastrophic vascular and biliary injury. Inside the gallbladder, stones form when three precise conditions align: the production of lithogenic bile, a period of structural or chemical stasis, and a site for nucleation. When cholesterol levels overwhelm the bile salts, pure cholesterol stones emerge. These are composed of over 90% cholesterol and typically present as solitary masses. This classification tree details pigment stones, which present entirely different chemical signatures. Brown pigment stones are formed from calcium palmitate and stearate. They are strongly linked to infected bile and parasitic infections like chlornorchiasis. Black pigment stones consist of insoluble bilirubin polymers and correlate tightly with hemolytic disorders, such as sickle cell disease or G6PD deficiency. Both pigment variants show a distinctly high prevalence across Asian populations, but the most common presentation overall is the mixed stone, bridging both cholesterol and pigment components into a single calculus. A stone with multifaceted geometric surfaces reveals a specific clinical history. These facets only form when multiple stones are forced together under pressure, indicating a gallbladder filled with multiple calculi rather than a solitary mass. The traditional medical mnemonic restricts the risk profile to the fat, fertile female of 40. Modern clinical data dismantles this. Biliary disease and gallstone formation occur aggressively across all age groups and demographics. Tracing the exact biochemical composition of an extracted stone dictates the next phase of care, steering clinicians to investigate systemic hemolysis or occult parasitic infections. Standard radiography is poorly equipped to diagnose gallstones because 90% of them are entirely radiolucent. Only 10% contain enough calcium to appear on an X-ray. When they are radio-opaque, they leave specific geometric signatures. A biradiate stone creates a classic seagull sign, while a triradiate stone forms the Mercedes-Benz sign. This simulated ultrasound sweep illustrates why it is the absolute investigation of choice for gallbladder pathology. A hard calcified stone blocks the sound waves, casting a distinct dark post-acoustic shadow downward. A soft tissue polyp allows the waves to pass through cleanly, leaving no shadow. Most asymptomatic gallstones discovered incidentally are managed conservatively. However, surgical intervention is strictly mandated when specific high-risk variables are present. This checklist dictates the absolute indications for prophylactic cholecystectomy. It includes polyps larger than 1 centimeter, Salmonella typhi carriers, diabetics, stones larger than 2 centimeters, and planned bariatric surgery. Most critically, it includes the porcelain gallbladder, a heavily calcified wall that carries a known 5 to 7% risk of gallbladder cancer. The post-acoustic shadow provides an explicit segregation of benign polyps from pathological stones. This specific imaging detail forces the clinical pathway toward algorithmic triage. When stones obstruct the cystic duct or neck, the resulting inflammation causes acute cholecystitis. The classic clinical indicator is Murphy's sign, strictly defined as an inspiratory arrest upon deep palpation of the right upper quadrant, not just general tenderness. Patients may also present with Boas sign, causing hyperesthesia over the right 12th rib. This flowchart tracks the Tokyo Consensus Diagnostic Criteria. Under these guidelines, a definitive diagnosis of acute cholecystitis is not made on symptoms alone. It requires a documented triad of local signs, systemic inflammation, and positive imaging. The classic ultrasound findings confirm a gallbladder wall thicker than 3 millimeters, pericholecystic fluid, and probe tenderness. While a HIDA scan failing to visualize the gallbladder at 30 minutes supports the diagnosis, ultrasound remains the primary diagnostic tool. The Tokyo criteria then segment severity. Grade 3 indicates organ dysfunction. Grade 2 covers moderate presentations, marked by a white blood cell count over 18,000, gangrene, or a palpable mass. Grade 1 covers mild presentations.
Fit patients proceed to early laparoscopic cholecystectomy, while unfit or severe patients often require delayed surgery and an immediate tube cholecystostomy to decompress the system. Severe inflammation can also occur in the absolute absence of stones. Acalculous cholecystitis predominantly strikes critically ill patients managing sepsis, prolonged total parenteral nutrition, or intensive care stays. Repeated acute attacks eventually degrade the tissue into chronic cholecystitis. Ultrasound reveals the classic wall echo shadow, or West sign. Histopathology will show Rokitansky-Aschoff sinuses deeply embedded in the wall. If these sinuses rupture, they trigger xanthogranulomatous cholecystitis, a destructive inflammatory state that closely mimics gallbladder cancer on imaging. Other severe variations require immediate recognition. Emphysematous cholecystitis is driven by gas-forming organisms like Clostridium. A completely obstructed Hartmann's pouch leads to an aseptic, distended mucocele. If that trapped fluid becomes purulent, it forms a highly toxic empyema. The Tokyo criteria eliminate subjective physician guesswork. They enforce a rigid, standardized trigger that separates the patients who need immediate laparoscopic intervention from those who require delayed tube decompression. This cross-section shows the mechanical consequence of untreated, recurrent inflammation. The inflamed gallbladder wall adheres to the adjacent duodenum and erodes, creating a cholecystoduodenal fistula. The gallstone passes directly into the bowel, completely bypassing the common bile duct. Despite the name gallstone ileus, this is a dynamic mechanical intestinal obstruction, not a paralytic state. Contrast-enhanced CT reveals the diagnostic criteria known as Rigler's triad: mechanical small bowel obstruction, pneumobilia indicating air in the biliary tree, and an ectopic radio-opaque stone. The stone predictably impacts in the narrowest portion of the terminal ileum, specifically the final 60 centimeters, mandating an emergency laparotomy to relieve the blockage. If the fistula formation and subsequent impaction occur proximally in the duodenum rather than the distal ileum, it causes a complete gastric outlet obstruction, categorized as Bouveret syndrome. A stone lodged tightly in the gallbladder neck causes Merizi syndrome. The stone externally compresses the adjacent common bile duct, cutting off biliary flow and resulting in obstructive jaundice. These specific anatomical complications prove that untreated cholelithiasis inevitably transitions from a localized inflammatory nuisance into a catastrophic mechanical or ductal obstruction. Moving past the cystic duct, we enter the primary outflow tract. This is the common bile duct. Pathology here shifts into two distinct origins: primary stones formed directly within the duct due to infection, and secondary stones that have migrated down from the gallbladder. When stones obstruct this pathway, the stagnant bile infects rapidly, causing cholangitis. The classical clinical presentation is Charcot's triad: right upper quadrant pain, spiking fevers, and jaundice. If the infection escalates, it triggers Raynaud's pentad. The addition of hypotension and an altered mental status indicates the infection has breached the local tissues and initiated severe systemic sepsis. This comparison matrix outlines the absolute bifurcated rule of ductal imaging. MRCP, utilizing magnetic resonance, is strictly non-invasive and purely diagnostic. ERCP uses endoscopy to enter the ampulla of Vater. It is an invasive, therapeutic procedure carrying significant risks of pancreatitis and duodenal perforation. Patient presentation dictates the tool. Low-risk patients with a bile duct diameter under 6 millimeters and normal liver function proceed directly to surgery, but intermediate or high-risk patients presenting with dilated ducts and deranged liver function mandate an MRCP first. Because invasive endoscopies carry inherent pancreatitis and perforation risks, utilizing the strictly non-invasive MRCP is mandatory for confirmation prior to any therapeutic intervention. Cholecystitis is managed through a rigid 3-scenario algorithm. The entire surgical pathway is dictated mathematically by the timeline of detection relative to the primary cholecystectomy. This flowchart maps the initial branch. In Scenario 1, common bile duct stones are detected before surgery via MRCP. The algorithm mandates an ERCP to extract the stones first, followed sequentially by a laparoscopic cholecystectomy. Scenario 2 covers stones discovered intraoperatively. The protocol shifts immediately to a laparoscopic common bile duct exploration, stone removal, and the insertion of a T-tube to maintain ductal patency. The T-tube requires a follow-up cholangiogram at 7 to 10 days. If residual stones remain, the Berheen technique is applied at 2 to 3 weeks, introducing a kaleidoscope directly through the established tract to retrieve them. Scenario 3 involves stones detected after the gallbladder has been removed. Once confirmed by MRCP, they are classified as residual if detected under 2 years, or recurrent if over 2 years. Both are definitively treated with ERCP and a sphincterotomy. Modern hepatobiliary management leaves zero room for clinical improvisation. The timing, the imaging modality, and the specific surgical intervention are mathematically dictated by anatomical location and algorithmic logic.